areas of unmet need for patients with kidney cancer, that's metastatic, we'll start with. I think we need to be able to have better immune therapies in the front line. I think we've gone, in my personal view, way in the wrong direction by combining anti-PD-1 with VEGF inhibitors. I think that may make the VEGF inhibitors better, but it's going to potentially harm the ability to see the long-term survivors that you can see with immune therapy. And so we've got to focus on making the immune therapy better rather than the targeted therapy better by understanding better what the mechanisms by which patients with kidney cancer escape the immune response. Second, I think we need to have an alternative treatment class besides immune therapy and anti-angiogenic therapy for the patients who don't respond to either of those treatments or who have become resistant. And maybe the HIF-2 alpha inhibitor, Belzutifan, will fill that niche, we'll see in trials. And maybe that's an agent that can be combined with other agents, not necessarily immune agents, but other agents that are driving kidney cancer, which are downstream of von Hippel-Lindau loss, upregulated, that can be potentially synthetically lethal with Belzutifan. And then finally, I think we need also to look at cellular therapy approaches, either CAR T cells or I said finally, but there's actually some more. We need to look at cellular therapy approaches such as CAR T cells or other engineered T cells or NK cells for kidney cancer. We also need better treatments for patients with non-clear cell kidney cancer. I think the unclassified non-clear cell cancer and the sarcomatoid non-clear cell cancer probably responds the same way clear cell cancer does. So that group is fine, but we really don't know what's the best way to treat papillary or chromophobe cancer, so we need better understanding of the biology of those diseases so we can figure out how to treat them. And then there's a lot of rarer types of kidney cancer where we really are lost, such as translocation kidney cancer or medullary kidney cancer, where we need a lot of work. I think we've made some progress in terms of adjuvant therapy for kidney cancer with pembrolizumab data being approved, and that's a great start. But we need to better understand who are the patients who are going to benefit from adjuvant therapy, and things like the Hoosier study that I talked about and presenting here may help identify biomarkers for anti-PD-1 in the adjuvant setting. But also we have to identify who's the most at risk for progressing so that we can combine who's going to benefit with who's at risk to identify who should get adjuvant therapy. And then in other cancers, we're actually seeing possibly more benefit from neoadjuvant treatment as compared to waiting until the surgery is done and giving adjuvant treatment. And so I think we have an opportunity to explore neoadjuvant treatment in kidney cancer as well, treatment before the primary is removed, and we'll start seeing some results of those type of studies over the next years, and maybe that will provide another step forward.